Hello, good evening.
Good evening, Grandpa.
Good evening.
We thank God for another wonderful week and then topic. From our moderator, we are starting a new topic today. But I want to know how far with the topic that we have treated before. If we have any challenge or any concern with it, so that we can also report it as soon as possible. Have we enjoyed the topics that we have treated? So, do you have any challenge? By the way, this is Kingsley, the deputy rep. Sorry, this is Kingsley, the deputy rep. So before the moderator comes, I want to know how far with the model 1, the things we have treated, Andrology 1, how far with it? Have all our questions been answered? Are we okay with it?
Kingsley.
Yes, please.
Yeah, so the last time I mentioned that the slides on the portal have been uploaded as videos. I mean, I think the first 5 or 6 slides were uploaded as a video. So I told Abdul to rectify it. It's still in the form of a video. I don't know if you can talk to him about it.
Hello, Rhoda, I mix your voice. It didn't come. Well, can you repeat?
Okay, so I said that the first 4 or 5 slides that were uploaded in the form of a video. instead of a PowerPoint or a PDF. So it's not easy to access it offline. Yeah, so I told Abdul that if he can change the format to PDF so that at least we can access them online rather than having to play the video to watch the slides. So I don't know if you can speak to him to rectify those. The remaining ones, he did upload them as video, but the previous ones that he uploaded were all in the form of a video.
Okay, all right. That part is well noted. But my submission on that, personally and from other point of view, please, have you tried watching the videos?
Yes, I have.
Okay, I think when you watch the video, it gives more understanding than the slides. I don't based on individual, but majority are saying that the video. So though I will channel your concern to him, but I think if you also try to watch the videos, the explanations and everything that are absent in the slides are well captured in the video. But then I will discuss with the facilitators to see if they can also do that. But even if the slides come, I think still try to watch the videos, because when you watch the videos, it gives better understanding. But then your concern is well captured. I will forward it to them as soon as possible.
Okay.
All right. Now, well noted, and I'm sure the coordinator too has taken note of them and to address them. I'm sure that you're going to have the benefit of both the audio and then the slides too. I submitted the first part of the module 2 to him, and I'm sure they should be ready for uploading any moment. All right. Thank you. Welcome back for another week. Actually, we're going to have a continuation of the previous topic, except that these are subtopics. And I'm saying that they're interesting because they actually reflect certain day-to-day observations. And sometimes some of the things that get people worried and probably will want to get answers from us as lab scientists, we may not be able to get the answers for them because we ourselves, we don't know. So the essence of saying that this week's or today's session is going to be interesting is the fact that it's going to unravel the science behind a lot of them day-to-day things that we observe in our male reproductive health. All right. So straight away, we're going to go to retrograde ejaculation. And retrograde, as you may know, is just going backwards. That's a retrogression. If let's say you are in school and then the report comes that you are retrogressing, what it means is that probably things are getting bad. All right, you are going backwards instead of forwards. All right, so we're going to look at this one, the pathophysiology of it. And before we can move on, we want to have an overview of the ejaculation process itself, which we have dealt with it extensively in the last week. Hey. We said that in the ejaculation, it involves two phases. Hey. The emission phase. Emmanuel and Christian, can you, right, thank you. Please, you are free to talk if you want to ask questions. But if you are just doing your own thing behind the scene, please, you try to mute. At any point in the course of our discussion, if you have anything you want to ask, please do. All right. So we, by way of overview, we said that in the ejaculation process, there are two phases. The first phase is the emission phase, where you have the sperm being carried from the store area, and you know the store area is the epididymis, and even with the epididymis, they are typically stored in the tail end. All right, now that's where they are stored. And then during sexual arousal, the sympathetic nervous systems become induced. Once they become induced, they are those ones that will force the stored sperms to be transported via the vas deferens from the epididymis to the urethra. And within the urethra, they are deposited at the posterior, the prostate end. All right, good. So that phase is usually accompanied by the sensation, the good sensation that we enjoy during sex, and that is the orgasm. So that whenever there's orgasm, it means that the first phase of the ejaculation has been carried out. All right. And then we said that once that has carried out, then it moves into the ejection phase. All right. Where sperm is going to be expelled. Now, expelled. We said that at that point, whether you continue with the sexual activity or not, the release will come. And that is what we call the ejaculatory inevitability. Inevitability means it's bound to happen. Whether you, and I said that once we go to the semiology concept or semiology session, and we're doing semen analysis, then the principle of ejaculatory inevitability will be used, because when somebody cannot masturbate, and for that matter, you are encouraging the person to, or you're advising the person to do the coitus interruptus, all you have to tell the person that once you have that kind of feel of that kind of sexual pleasure, please withdraw. So people call it withdrawal method. The coitus interruptus, people also call it withdrawal method. Some people think that they want the release or the fluid to start coming before they remove it. Once you do that, you are going to miss the first portion of your semen. And we said that during the ejaculation, it occurs in fractions. And that's what we call fractionated ejaculation. And we've also come to realize that the first portion or the first fraction, which comes off, contains about 70% of the sperms. And so, and the one which comes first. So if the person doesn't know and he wants to wait until the sperm, or for that matter, semen is coming out, he will have lost that first portion. And that's also going to compromise the results, the test results. But once you explain to the person that if you get that feeling, remove it. Whether you remove it or not, there is a principle called ejaculatory inevitability, where it will compel your semen to come out. Once you get this idea and you advise the patient, I'm thinking that even is using the unpopular coitus interruptus method, you are likely to save the patient from losing the first fraction. So that point should be well understood. Right. If somebody says that, oh, I get a feeling that I get that orgasm, meanwhile, there's nothing coming, then you as a scientist, you understand that then if there's, because the first phase has been completed already, if the second phase is not happening, it may have happened, except that the thing did not come out. All right. And that's where you begin to suspect the concept of retrograde ejaculation. So please follow the discussion and understand it. Once you understand it, you may not even read at all, but you'll be able to always give a scientific explanation to some of these concepts. Right. So you're saying that at the point of the ejection, that's the second phase. The second phase where the semen is going to be expelled. Right. What should happen? What should happen is that the sympathetic nervous system is usually contractile in nature. Remember, we said that in the ejaculation, you're going to have parasympathetic nervous activity, which will actually relax the muscles. So there's that relaxation component. However, with the sympathetic nervous system, it contracts. Okay, so this is going to contract Once it's going to contract, then it's going to like tighten something. So the muscles at the neck of the bladder, under the influence of the sympathetic nervous system, is going to contract. They are not going to relax. If they relax, of course, it means that they open up. All right. But once they contract, it means that they will have to tighten up. So that system must happen. If it happens, then it means that the bladder neck muscle is tightening the neck, say that urine will not flow. All right. Anything that will disrupt that activity is going to cause the bladder neck to lose. And once it loses, remember that the first phase has already caused the sperm to be transported to the prostate already. All right. And then once the neck is now also loose, then any fluid will move through the area of least resistance. Any fluid at all will move. If you pour water on the ground, I mean, it will move according to least resistance. Okay, so once you have the semen, and for that matter, the seminal fluid in the prostate, and the neck is not tightened, then the least area of resistance is through the bladder area. So it will move there straight away. And so once it moves there, as we move along, you understand that it could be partial or complete. Once there is partial closure, it means that, yeah, the path is there, but there's still some, it's not completely tight. So it means some will go in, some will come out. So it means that you get some of the semen coming out. But you understand that the volume which is supposed to come out completely, some have gone into the bladder and some have come out. So you are going to get some of the semen at all costs. But you realize that the volume which is coming out is small. Once it's small, you as a scientist should suspect that some of the semen may have gone somewhere. And then all these issues about retrograde ejaculation can now be investigated. All right. So now during normal ejaculation, like I said, the semen will move forward. All right. Semen will move forward. And the medical terminology for antegrade or anti means forward movement. All right. So antegrade means forward movement or normal movement. If you're talking about the antegrade blood flow, what it means is, what is the normal flow of blood? So that would mean, so antegrade does not necessarily mean forward movement, but normal movement. So normal ejaculation, what should it be? In normal ejaculation, you expect the semen to come out. So that is antegrade ejaculation. So these are some of the terminologies I want you to appreciate so that once you are discussing or talking or explaining some of these things and these terminologies come out and you understand them, you yourself will know that, yes, you know something more than the ordinary scientists. So that is why I'm encouraging you to listen and listen good. So the normal movement of a normal ejaculation is for it to come out. Once it goes up backwards, that's a different story. So our normal ejaculation goes through a process called antegrade ejaculation. And this is what you see, that the semen, and for that matter, seminal fluid, will have to move from the prostate and out through the urethra penis, through the urethra and the penis and out of the body. All right. And that is, like I said, that is what is called antegrade flow. All right. So the opposite of antegrade will be what? The opposite of antegrade will be what? Backward. Because the forward movement is antegrade. So therefore, backward movement becomes the retrograde. So that's That's where you are now coming to. All right. So the previous narration is to give you more information into what you have already discussed. That is the normal ejaculation. And we are introducing the new terminology, antegrade, and now you understand it. Good. So what is the mechanism of retrograde ejaculation? Like you said, it's a condition whereby all or part of the semen flow backward into the bladder instead of flowing forward through the urethra to the outside. So the normal flow of semen is for it to come out through the urethra. All right. So if now it is moving backwards, once it moves backward, where will it go? It will go into the bladder, and that is the retrograde ejaculation. So it is also abbreviated as RE, not routine examination. In this concept, RE here is retrograde ejaculation. Now, during sexual intercourse, the bladder neck, like I've said, the muzzle at the bladder neck get close. And the closure is to prevent spillage of the semen into the bladder. Retrograde ejaculation happens when the bladder neck sphincter fails to work properly, allowing backward flow of semen into the bladder instead of going through the urethral meatus. And I'm sure you understand the urethral meatus, that's the opening of the urethra to the outside. So this just better and further explanation to all that I've said before. Good. So this is the mechanism of retrograde ejaculation, where the semen, instead of coming out through the urethra, is now going to move backwards into the bladder. You have the same thing here. All right, good. So in retrograde ejaculation, semen enters the bladder instead of going out through the urethral opening. All right, good. So still on the mechanism of retrograde ejaculation. So during normal ejaculation, semen is expelled out of the penis. This is well noted. Semen is prevented from entering the bladder because the bladder neck muscle of the neck muscle of the bladder, which is also called the bladder neck muscle, closes tightly at the moment of orgasm. Okay, so remember, orgasm is stimulated or influenced by sympathetic nervous system. Sympathetic nervous system causes contraction. Okay, so this contraction is what is causing the bladder neck also to tighten up. All right. If it doesn't, if anything prevents the sympathetic nervous system from working, then it will mean that the parasympathetic, which is actually causing the erection, will not be operating. And remember, parasympathetic nervous system will relax, causes relaxation. Once it causes relaxation, then the bladder neck muscle will also relax and open up. Okay, but interestingly, this is not the case. Rather, you have the sympathetic nervous system working, which is causing the contraction. Okay, that's why we said that once you ejaculate, it is likely to be followed by detumescence. All right, because detumescence is also influenced or induced by sympathetic nervous activity. It is this sympathetic nervous activity which is also fueling the first phase of ejaculation, which is the emission. All right, so once you understand all these things, it makes the whole concept or mechanism very understandable for you. All right, so in retrograde ejaculation, the bladder neck muscle that closes during normal ejaculation does not function normally. I think we said this already. Right. Closure of the bladder neck and seminal emission are initiated via the sympathetic nervous system, which I've explained already. And remember, this sympathetic nervous system is coming from the lumbar sympathetic ganglia. You know this already. All right. So any factor which disrupts this reflex activity inhibits bladder neck muscle contraction. All right. So what we're saying here is that if anything will disrupt the sympathetic activity, then it will also result in a situation where the bladder neck will not close properly, and therefore will cause the flow back of the semen into the bladder. Right. So still more explanation on the retrograde ejaculation. Here we're talking about classification. Like you said, retrograde ejaculation happens when the neck or the bladder does not close, leading to the backward flow. The condition can be classified as 1, partial or incomplete retrograde ejaculation. Now I'm saying that here, we're saying that for the retrograde ejaculation to occur, it means that the bladder neck is loose, it's not tightened. But the loose can be completely loose or partially loose. Okay, once it's partially loose, what it means is that yes, it will allow some of the semen to flow back into the distance, into the bladder, but still some will also be able to flow in the normal fashion. All right, so what it means here is that there will be reduced ejaculate volume, like I explained earlier. Reduced ejaculate volume is hypospermia. Right. So once you're observing hypospermia, especially if it happened first, and then you say, probably the patient may have produced the semen via coitus interruptus. So now you want the patient to, let's say, masturbate. Unfortunately, the patient is able to masturbate. Still, he produces very low volume. Straight away, you should suspect. You know, one of the things that will lead you to proper diagnosis is your degree of suspicion. All right. So if you want to do malaria test, first and foremost, you should have suspected that the patient has malaria before you go and do the test. All right. So, and what will prompt you to think that the patient has malaria? Of course, some of the classical signs and symptoms of malaria will have manifest. Then you said, okay, I'm seeing this, I'm seeing that, I'm suspecting malaria. Then you go and do your BF. So the same thing, you are suspecting that the patient could have partial retrograde ejaculation because anytime he produces semen for you, it's just very little. Initially, you thought that probably he went through the coitus interruptus, for which matter he may have lost some of the semen before bringing it out. Now, you have asked the patient to masturbate, still the volume is inadequate or the volume is reduced. That should be your basis for suspicion of retrograde ejaculation. And then it can also be complete retrograde ejaculation. So once there's complete retrograde means moving out. So it means that everything has gone into the bladder. So if everything has gone into the bladder, what will come out? Nothing will come out. So then it means that here there is complete absence of semen. The patient will have gone through that arousal, sexual activity, and will have gotten the feeling of an orgasm, yet nothing is coming out. All right. So we also call this dry orgasm. Dry orgasm because the patient will tell you that, no, I get that pleasure, that yet there's nothing coming out. That's called dry orgasm. Okay. And that should tell you that the semen has moved backwards instead of coming forward. Now, so the two, aspermia and dry orgasm, are the same. The aspermia is saying that, remember, A means absent. We said this, most of the medical terminologies, if it is preceded, if you have the prefix A or an, it tells you absent or lack of. So aspermia means not spermia here, not talking about the sperm cells themselves, but the whole seminal fluid. All right. So remember, you have hypospermia. It doesn't tell you that there is low volume of sperms. No, but rather semen. Once we do the seminology, then you are going to see the difference between spermia and then the seminal fluid and so forth and so on. But here you say that spermia is not talking about a sperm, it's talking about the whole ejaculate or the fluid, the total volume. So aspermia means here there's absence or lack of the seminal fluid. All right. And we're saying that A means absent, and absent means nothing came out. So that will tell you that you are likely dealing with complete retrograde ejaculation. And it's also called dry orgasm because the patient will have experienced orgasm, yet nothing is coming out. So that's dry. So the words aspermia and dry orgasm can be used interchangeably, but they actually mean one and the same thing. and they actually give a suspicion for complete retrograde ejaculation. Good. So, like we said, preliminary diagnosis, what to make you think that the patient has retrograde ejaculation. So retrograde ejaculation may be suspected in the following conditions. Whenever the semen volume is less than 1 ml, whenever the semen volume is less than 1 ml, that is producing very low semen volume, which we call hypospermia. This is what we've talked already. Once the patient is giving you less than 1 ml of semen, well, initially you would think that probably some of the specimen has been lost, either through the process of collection, or even probably if the patient collected the semen and then he didn't close the container very well, and probably during the transportation, the transit, it may have leaked something. So you may be giving yourself excuses or reasons why probably the semen volume is low. All right. But especially once you repeat and then it still gives you this low volume, that should be your prime suspicion. And then, so that's the first one. Secondly, producing no semen at all, which we call the aspermia or the dry orgasm, in at least two samples. So the patient, that's the first one. So as a Miami home, then you ask the patient, but do you get the feeling of an orgasm? Say, yes, I get the feeling of orgasm, but nothing is coming. Okay, so in that case, you can always give a second opportunity. You can prepare the patient again, let him do, if it at least on 2 occasions, if you are getting the same thing, your suspicion should be very, very, very high for, in this case, that would be complete retrograde ejaculation. Now, a third suspicion is when the patient produces cloudy urine after sex. All right. So in this case, it can be post-orgasm. Remember, once it is post-orgasm, what it means is that there was an orgasm, but the patient did not actually produce semen. All right, that would be a post-orgasm urine sample. It is not post-ejaculation. The ejaculation is when the 2 phases have all been completed. The first phase of emission, the second phase of the ejection. This one, the ejection is what we actually observe, and then what we take as ejaculation. So if the ejaculation itself did not come, the patient felt that there's been orgasm, then the specimen we are going to collect will be post-orgasm specimen. All right. So this I want you to understand the whole concept in a manner that you yourself will get a feel that, yes, you are appreciating the principles and then the physiology of the condition that you're describing. Okay, right. So there are certain words that can be used interchangeably, but even when they are being used interchangeably, you should understand why it is called this and why it is called that. All right. So, and in this case, the urine becomes cloudy because the semen has gone into the bladder and have mixed up with the urine, and technically it makes the urine cloudy. So once you're observing all these things, it gives you a basis for high suspicion of retrograde ejaculation. Good. So let's consider some medical causes. Medical causes. So first, we've said that we are dealing with the sphincter, and for that matter, the bladder neck system, which should be tightened. So anything which will cause the loosening of the muscle should be a cause. And here we are saying that it is supported or it is induced or influenced by sympathetic nervous system. So if there is autonomic neuropathy, remember when we say neuropathy, pathy, which is the suffix of a medical term, becomes pathological. It's like a disease condition. So when you say neuropathy, you're talking about the disease conditions of the nervous system. Now, autonomic here, you're dealing with sympathetic and parasympathetic nervous system. All right. So when we say autonomic neuropathy, they're saying that something has happened to cause a disease or malfunctioning of the parasympathetic and then the sympathetic nervous systems. That's what it is. When you say etiologic, it means that you don't even know the cause, but something has caused a damage to the sympathetic nervous system. Here, emphasis is on the sympathetic and not the parasympathetic because we are dealing with ejaculation, and ejaculation is induced by sympathetic, not parasympathetic. So it means that here our focus will be more on the sympathetic. If you are explaining ejaculation itself, all right, if you are, if you are talking about erection, then here too, our emphasis will be on the parasympathetic. Because you are dealing with ejaculation, and you know that ejaculation is induced by sympathetic here, so any damage that will affect the sympathetic nervous system will also lead to retrograde ejaculation. All right, so these are the things. So any condition at all which will cause the autonomic neuropathy, and for that matter, sympathetic nervous system damage will lead to retrograde ejaculation. So that will be a major medical cause. And we say that medical conditions like diabetes, mellitus. Who can tell me the difference between diabetes mellitus and diabetes insipidus? Diabetes mellitus, diabetes insipidus. Who can share about the difference between the two? Don't let me call you by name, so this one is basic biochemistry. Diabetes, or you don't know that we have diabetes insipidus and diabetes mellitus. You should know. What's the difference between diabetes insipidus and that? Who is using the iPhone? Whose this iPhone without a name? If you continue to do this, I will instruct the coordinator to take you off. You don't want any person to be enjoying for not paying. So the iPhone, please, you better identify yourself properly or we take you off. Yes, what's the difference between diabetes insipidus and diabetes mellitus? Yes, Clement want to talk. Yes, Clement. Chris too want to talk.
Yes, Grandpa.
Yes, sir.
Okay, so the diabetes mellitus is a metabolic disorder affecting sugar regulation.
Okay.
Then the insipidus is a hormonal disorder affecting water balance in the body.
Okay, that's a good idea. But if I'm marking you, you see, the technicalities do not come out. You see, why are they all diabetes? They are diabetes because they are all characterized by polyuria, where you have massive outflow of the urine. Okay.
Yes,
right.
Please.
So they all have so if you are in the lab, how will you differentiate the two? Diabetes insipidus and diabetes mellitus in the lab? Very simple. They are, because they all have polyuria. They are producing a lot of urine frequency. All right. So if the doctor is suspecting, once you are in the lab, you should be able to differentiate the two very easily. Yes.
So, Grandpa, I can see that maybe like the mellitus, the urine is having a sweet smelling.
So be technical.
Yes.
Like I'm saying, when you said all that you said earlier was good, but it lacked the technicality that I expected.
Okay.
So of course, they all have polyuria, and therefore the urine will look because you have too much of water in the output. The urine will all be very, very clear. Okay, almost colorless in all the two. So you can use the appearance to differentiate. But one will have sugar. One will have sugar, one will not have. So one will, of course, test glucose positive. One will test glucose negative. Then most importantly, specific gravity. Because once you have urine, a large volume of urine, and then they are all polyuria. One has sugar, and therefore it contains that osmotically active ingredient, which is the sugar, and therefore let me put it this way: there's sugar in this thing, and therefore specific gravity in the one with the sugar will be high. Do you agree to that?
Yes.
Yes. The osmolarity, if you have protein and sugar, their osmolarity will be high, and therefore osmolarity also consequence with the specific gravity. Therefore, one will have specific gravity. One will have very low specific gravity, and so the baseline for specific gravity is 1010. When I say 1010, the other day I was telling you about mnemonics. Mnemonics. Who can spell mnemonics? I'll spell it there for you the other day. I want to know whether you remember. Mnemonics. Spell mnemonics. Yes, Alex. Mnemonics. Alex, don't talk. Can you spell mnemonics for me? This is spelling bee. Clement. Clement, you like unmuting all the time. Clement, is in your pin. Clement, spell mnemonics. Spelling bee for us. Mnemonics.
G-E.
Come again.
M-O.
Come again.
G-E.
P.
Hello.
Yes.
D-E.
D as in what?
Hello.
Yes. I can hear you properly.
Is the network.
Okay. D.
E.
Did you say D? D for Daniel.
Yes.
Mnemonics. And you are starting with D.
Hello, Grandpa.
Yes, sir.
Grandpa.
Dennis.
Yes, sir. It's BNEUMONICS.
That is wrong, please.
Hello, Grandpa, let me spell it.
Yes, please do.
Okay, mnemonics is M-N-E-M-O-N-I-C.
Start with M-N-E. Yes. Remember when I was talking about it the first time, I said it. This spelling B. Class 1 spellings. Mnemonics is M-N-E. Then you continue. All right. Mnemonics, anything that will help you to remember something. And I said that specific gravity, the baseline reference is 1010. You see? So when I say 1010, it helps me to remember. Meanwhile, 1010, specific gravity starts with 1 point something. So when I say 1010, it means that I'll just put down 1010, which is 1010. Then because it's 1 point, then I'll place the point here. I'll place the point after the 1, so it becomes 1.010. That's your lower reference range. And then the upper reference range is 1030. So 1010 to 1030. So 1030 will also be 1.030. So anything above 1.030 is happy. The specific gravity is so high and it's likely to be diabetes. Once it is lower than 1.010, okay, it's likely to be diabetes insipidus. You see, but a lot of things can, if the person is also taking too much water, it can also dilute the urine to the extent that your specific gravity can go below 1.010. Okay. So
Grandpa,
that's just, yes, sir.
Grandpa, please, some of the urine strips, the upper limit on it is like 1.030. I think that's the last upper limit.
Okay, so if it's consistently giving you 1.0, the upper limit, if if you are getting consistently 1.030, then it means that this is likely to be a diabetic patient.
Oh, okay. Okay. Thank you very much.
So you are not, please, you are not dealing with urinalysis. If you can deal with urinalysis in another forum, but this is just by the way. So we are saying here that conditions like diabetes mellitus, and remember we said that diabetes mellitus can cause a lot of neuropathies. It causes a damage to a lot of the nervous system. So once a patient is diabetic, they could be, and diabetic is also a chronic condition. It means that you have it for a long time. So over time, they can cause neuropathies. And these neuropathies could be one that is linked to the sympathetic nerves for ejaculation. So what will happen? All right, so it means that you could experience retrograde ejaculation. In fact, retrograde ejaculation has been known to be one of the earliest signals for diabetes mellitus. All right, so this art, you see, we are scientists, and so we should be able, in our area of operation, we should be able to know more than the doctors. When it comes to our area, we should know more than them. All right, so that is why I'm saying that the program you are going through, at the end of the day, you yourself should know that you have learned something. You have learned something. The money aspect, no, I don't discount it because nobody has money. But once you are paying for it, you should be able to carry along with some new knowledge. All right, good. So, and then multiple sclerosis, spinal cord, you know all these things. All of these conditions can damage the nervous systems, especially those ones that affect the sympathetic nerves of that control the ejaculation, for example. And so you are likely to get retrograde ejaculation. And so what it means is that you are getting medical retrograde ejaculation because there's a medical condition. All right, good. So there could also be some surgical causes. So we've talked about a medical cause that could give you retrograde ejaculation. Surgical causes, of course, will include prostate gland surgeries. If there has been prostate gland surgery, you should expect, or bladder surgery, colorectal surgeries, transurethral prostatectomy, transurethral bladder neck incisions. All these are surgical interventions. All right. And once you've gone through any of these things, they are likely to also compromise or damage the nerves that also control erection and ejaculation. I hope you are following me. Right. So anything that, for example, we said that the nerves that control the ejaculation and erection are always in the sacral region, and the sacral region nerves usually serve or supply the pelvic area. So if there's any operation within the pelvic area, where no doctor will intentionally damage anything, but there could be an inadvertent damage to some of the nerves that can also give you these side effects. All right. Right. So in the lab, this is where I want you to take very good note. In the lab, yours is to make laboratory diagnosis. The clinicians can give their clinical suspicion or clinical diagnosis, but they depend on laboratory results or laboratory investigation to confirm what they are suspecting. And this is where you as lab scientists should also master. So there's what we call post-ejaculatory urine analysis. All of us know about urinalysis. Urine analysis, when you combine, becomes urinalysis. So post-ejaculatory urinalysis become PEU, not pediatric emergency unit, please. This PEU is not, just as we said, RE for retrograde ejaculation is not routine examination. So you should know here that our PEU here is not pediatric emergency unit. It is post-ejaculatory urinalysis. Okay, this is what me and you as lab scientists, this is what we will depend on to confirm a suspicion of retrograde ejaculation. All right. So to diagnose retrograde ejaculation, it is necessary to evaluate urine after ejaculation. So if there is an ejaculation, remember we said that even if there's retrograde ejaculation, it could be partial or it could be complete. If it's partial, it means that some of the semen will necessarily come out. Okay, so if you are collecting the urine after that process, after the ejaculation process, then that will be post-ejaculation or post-ejaculatory urine. However, if the person masturbated, okay, if you masturbated and then you are producing urine after the masturbation, then that could be post-masturbatory urine examination. Please, these terms, probably they can be used interchangeably, but like I've said, you should appreciate why sometimes you read somewhere and then you come across this term, then another time you come across this term. They may be the same thing, but you should understand the concept of why they are so called. So when it's post-masturbatory, it means that there was masturbation, at the end of the day, there was nothing came out and you are producing urine. So that is not post-ejaculatory. That is post, but at the end of the day, it's the same thing. But what I'm saying that these are terminologies which you must appreciate and understand them very well and be able to use them at the right time. But sometimes too, probably the doctors may only be familiar with post-ejaculatory urinalysis. So if you go and use post-masturbatory urinalysis, that could also create a problem. But you will know when to use what. Okay, all right. So post-ejaculatory urinalysis is a test performed on urine after ejaculation or after masturbation, primarily to confirm or rule out retrograde ejaculation. Actually, diagnosis is based on the absence, it's based on the absence of sperm in the antegrade ejaculate. Remember, we said that antegrade ejaculation is the normal ejaculation. So in the normal ejaculation, you didn't see anything. All right, there's absence of sperm in the antegrade ejaculation. Now, if in the post-masturbatory or post-ejaculatory urine sample, you're able to see something, then it confirms your suspicion or confirms retrograde ejaculation. I don't know, I'm hoping that you understand this point. Diagnosis is based on the absence of sperm in the antegrade ejaculate. And you are saying that the antegrade ejaculate is the normal ejaculation, is the forward progressively produced ejaculate. That one, there was no sperm in it. However, in the one from the post-masturbatory urine, there was, or you have seen a sperm. That alone should confirm that then the sperm had moved into the bladder. Good. There's something interesting here. I want you to take very good note. I want you to take very good note. Post-ejaculatory urine test for fructose. Post-ejaculatory urine test for fructose. Remember that whenever you are talking about this, you do urinalysis. And urine analysis, you have the physical examination, which is the appearance of the urine. We have the chemical examination, which you use your strip, excuse me, to check for your glucose, your protein, so forth and so on. All right. And then lastly, you also do your microscopy. You spin and then work on your sediments. All right. So whenever you talk about urinalysis, you are talking about these three dimensions. So you've mentioned that for the first part, which is the physical examination, you will have suspected or you will have observed that the urine has become cloudy. Okay, so that will be your first thing, but you can't use that one to confirm because the urine itself may have been, if the patient already has some infection already, then the urine could be cloudy anyway. All right, or if the patient produced the urine from the house, the patient, you ask the patient to masturbate or ejaculate, and after that produce urine, bring it to you in the lab, and decides to bring the urine later to you in the lab, the urine will already have been cloudy anyway. So cloudiness cannot confirm retrograde ejaculation. The fact that post-ejaculating urine sample is cloudy cannot confirm retrograde ejaculation, because a lot of other things, a lot of factors could also cause the urine sample also to go cloudy. I hope that point is clear. So the appearance, the issue of appearance cannot confirm, can only also probably increase your degree of suspicion, but will not confirm. Here you're dealing with confirmation. The same thing will happen to what we're going to talk about now, the fructose test. Now, fructose is present in semen samples. I think we have made this abundantly clear that the source of energy or carbohydrate source for the sperm viability is the fructose. And the fructose is produced from the seminal vesicles. All right, so seminal fructose levels are typically measured as part of the semen analysis to evaluate the function of the seminal vesicles which produce fructose. What we're saying here is that as you move to seminology and you do semen analysis, you'll see that one of the tests which you'll be taken through is fructose testing in semen. A lot of us don't do them in our labs. But like we said, whenever you do semen analysis and there's an anomaly, you should be able to suspect where it is likely to be coming from, where the problem is likely to be. So if you are suspecting, for example, that the semen is not clotting, sample has been produced, it is liquid, almost watery, and it never gelled, straight away you should suspect that there's a problem from seminal vesicles, because they are producing the coagulating factors, or the gelling, or the coagulating factors. So if the thing is not coagulating, you blame the seminal vesicles. Seminal vesicles produce about 60 to 70% of the seminal volume. So if the semen volume is low, you should suspect the seminal vesicles. And to make it more, what you see that semen contains fructose. All right. And fructose is coming or produced from the seminal vesicles. So you should be able to assess the seminal fructose level. Once you do that, and then you see that it has a low fructose level, then it confirms absolutely that the seminal vesicles has a problem. All right. So now you are saying that you are suspecting that the semen has moved into the bladder. And for that matter, you have picked urine post-ejaculatory. All right. So it means that once you test fructose from the urine and it is positive, then that could also confirm that there has been a mix of urine with the ejaculate. Does it make sense, please? Does this analogy make sense?
Yes, please.
Yes.
Grandpa, please come again.
Hello. What I'm saying is that all of us know that the semen has fructose. That is the source of energy for the sperm viability. Is that point clear?
Yes, please.
Where is the fructose coming from?
The semen. The seminal vesicle.
So, for example, if let's say you do your semen analysis, like I said, if you do your analysis and there's an anomaly, there's a report, you should be able to have an idea about where the problem is coming from. Not just say the other day when we talked about hematuria, and then I said that if there are dysmorphic red cells, I hope you remember that point. If there are dysmorphic red cells, the only way you can have dysmorphic red cells is when blood, during the time of the filtration, the ultrafiltration, if the glomerular filtrate is compromised, blood will force itself out. Normal blood, even protein, should not be filtered. But if the glomerulus is compromised, then blood itself will filter. But during the process of filtration of the blood will squeeze itself out. And by the time the blood come out, the morphology will have been compromised. So you get challenged morphologies, RBCs of various shapes. These are called dysmorphic red cells. And once you see the dysmorphic red cells in your urine, you don't just report red cells in the urine. Because if you report, even if at the urethral meatus, if there's a scratch there, and then you are bleeding there and mixes up with the urine, is it still not hematuria? So as lab scientists, you may go beyond just reporting RBCs in urine, and then also report on the morphology of the vessels that you saw. And that can give you an idea about the source or the potential source of the RBCs within the urinary tract. That makes you a scientist. So we're saying that, yes, you get a semen, you do a semen analysis. The report, the report shows some anomalies or abnormalities. You should be able to suspect where the anomaly is likely to be coming from. And I'm giving instances where, if let's say the urine volume is low, if the urine volume is so low, knowing that the larger proportion of the ejaculate volume is coming from the seminal vesicles, it should tell you that then probably the seminal vesicle has a problem. So that will be your suspicion. But your test, your proper test of diagnosis will be to assay or analyze the fructose content of your seminal fluid, because along the line, no accessory organ produces fructose other than the seminal vesicles. So if you're able to, and you're already suspecting that the seminal vesicle has a problem, then if you do your seminal fructose test and the test shows that you have low fructose level, then that will confirm that seminal vesicle has a problem. That is why your fructose level is low. This is what we're coming up to. Then we are also now coming back to say that now we say that the seminal vesicle don't have a problem. Nobody has a problem, but except that instead of the semen coming out antegrade forward out, rather they moved backwards and then went into the bladder. So now you are going to have urine mixed up with the bladder. Sorry, we are going to have the within the bladder urine mixed up with semen. Is it not reasonable to also say that then, if that's the case, then the fructose level in the urine, the post-ejaculatory urine, will be high? Is it not reasonable to come to that conclusion?
Yes.
Yeah, it is very reasonable. That also, if I'm able to also assess the fructose content of this post-ejaculatory urine and find out that, oh, if the fructose level is high, then it confirms that there has been retrograde ejaculation. That is where we are coming from. So apart from the physical appearance, which is the cloudy, we are moving into the next level, which is the chemical examination. The chemical examination here, we are targeting fructose, because fructose is the carbohydrate which is found in the seminal vesicle. Sorry, found in the seminal vesicle, and for that matter, also present in the semen. So once semen has mixed up, with the urine, if I'm able to now test for presence of fructose in this so-called post-ejaculatory urine, and I found out that it is positive, then that could tell me that, yes, then there has been a flow back of the semen into the bladder. Does it make sense now?
Yes, please.
Good. However, even though people are proposing or thinking, yes, some researchers are using the fructose test level, but it is also challenging, just as we talked about the cloudiness, because it is not only, anything can also make the urine cloudy. So if you saw a cloudy urine after ejaculation, you can confirm that it is due to retrograde ejaculation. Similarly, if you have fructose in the urine, it can also confirm, it can still be a suspicion. Okay, it can still be a suspicion, because, you know, just as we have glucosuria, you also have fructosuria. Okay, you can have fructose, if somebody have fructose metabolism abnormality in fructose metabolism, why not? Remember, anything that you take in, if you have lactose, if you have, especially in children, you know, they have lactose intolerance. Okay. You could also have fructose intolerance, where fructose metabolism could be compromised. In that case, then the fructose will have to be excreted through the urine, because the body has been unable to metabolize the fructose due to some genetic inheritance, genetic abnormalities. So if there are genetic abnormalities, that will lead to the body's inability to metabolize fructose. Then the fructose will have to be getting rid of, excreted. So the presence of fructose in the urine cannot be used as a diagnostic marker for the retrograde ejaculation. Are you following the discussion, please?
Yes, please, Grandpa.
So just as we say that all this you can have, you want to use laboratory diagnosis, you should know which methods are available and what are the challenges affecting those methods. So we cannot rely on the appearance, the cloudiness. We cannot rely on that. We cannot also rely on the fructose, even though it is possible that the fructose that you are seeing in the urine may be coming from the semen. But there could be other causes of fructose in the urine, and therefore it makes the conclusion very, very challenging. So in retrograde ejaculation, fructose levels can be elevated in the post-ejaculatory urine sample due to semen mixing with it. Nonetheless, fructose in the post-ejaculatory urine testing is not a reliable diagnostic marker. And this is where I want you to take note. Right. When we come to proper semen analysis and you're dealing with fructose testing, then we talk about this. But like we're saying that even testing for fructose in the urine is not a reliable method. So why do you waste our time? But over there, the concept is in the aldose ketose differentiation. You know the aldose ketose, how to differentiate between the aldose and then the ketones or the ketosis. All of you, do you have experts in biochemistry? Do you have some of you? You have some expertise in biochemistry. Is any one of you here who is an expert in biochemistry? All of you are hematology.
Grandpa, I did biochemistry.
You did biochemistry.
Yes, please.
So can you tell us the key difference between the aldose and then the ketose?
Okay. Aldose and ketose.
Okay.
Grandpa, I see ketone in the urine.
No, not ketones. Not ketones. I say ketose.
Ketose.
All right. So, all right. Yeah, that's just that way. Don't worry. But you know, glucose is an aldose, and fructose is a ketose. You know that. This is basic biochemistry. Fructose differentiating when you are doing your carbohydrates. I think first year, second year, you'll be doing this basic biochemistries. And you do the carbohydrates and you come across the fructose, the hexoses, and then those things. So a key example of the aldose is glucose. And the key example of the fructose, of the ketose is the fructose. And you have a method, this Cellulose technique. Okay. So these ones they are basic fundamental, or you've forgotten them. See, in one thing about the science education is that, or laboratory science education is that you don't throw away your basic sciences. All those things you did in the basic science, you need them to appreciate the mechanisms and principles of the big things that you be doing in the lab. So if you forget about your basic anatomy, physiology, biochemistry, all those sort of things, you end up doing the test in the labs. But if it comes to explaining the science behind the test, you see that you will find one thing. So please don't forget about them. All right, good. So so a test, when it comes to the testing for fructose, it is rather significant when you are dealing with seminal fructose, and therefore at that level you talk about how to test for fructose in semen. But here we're not going to talk about it, because even if you talk about it, we say that it's almost irrelevant, it's almost unnecessary. Okay. All right. So you just mentioned that people may use the fructose test to try to confirm diagnosis of retrograde ejaculation, but it is not a reliable diagnostic marker. This is what I've said all along. So now these are some few points. The accuracy of PUU, and for that matter, post-ejaculatory analysis fructose test method is questionable due to a number of factors. And I've explained that you can have fructosuria in conditions where even if you overtake some lactose-rich diet, you may end up getting fructose in the urine, because you know that lactose, when you break up lactose, what do you get? If you break up lactose, what do you get? Yes, these are, say, fundamentals. The iPhone man who is using the iPhone, yes, well, if you break up lactose, what do you get? The iPhone man, if you break up lactose, what do you get? You know that is an example of a disaccharide. Eh? These are all very, yes.
Grandpa, it gives you energy. If
No. I'm talking about if you
and galactose.
fructose.
No. Try again.
Grandpa, please the question again.
I say somebody said glucose and galactose. I'm saying that is wrong. But if you break up lactose, what do you get? As a disaccharide, the monosaccharides that you get, what are they? Saccharin.
Glucose and galactose.
No. Somebody said it, I said no. And then you are repeating it. Yes, Rhoda.
Is it sucrose?
No.
Say glucose and glucose.
It's fructose and glucose. Go and check. If you break up lactose, you get fructose and then glucose. Of course, glucose metabolism becomes easy, but the fructose metabolism goes to a lot. So if the person is unable to convert the fructose, then it will be excreted, like I said. All right. So there are various ways of getting excess fructose in the system, and for which it may be excreted through the urine, and so it makes it unreliable to use fructose testing in your PU as a diagnostic marker. All right. So current diagnostic practice for RE, which is retrograde ejaculation, focus on identifying sperm in the post-ejaculatory urine. So once you're able to get sperm in the post-ejaculated urine, you're already suspecting that the semen has moved into the bladder. And so if from your post-ejaculatory urine, you're able to get sperm, then that is more confirmatory. So diagnosis of rhetorical ejaculation is confirmed if you are getting more than 5 sperm per high power field. All right. As we move along, that could also be questionable because what if the patients are also an azoospermic? The patient, yes, has ejaculated all right, but the patient has testicular failure, he didn't produce any sperms. And then along the line too, there's rhetorical ejaculation. So if there's rhetorical ejaculation and then the patient is already azoospermic, you also find no sperm in the post-ejaculated urine. But the catchword here is that before you will have done the post-ejaculation, you will have already done the patient's semen analysis. And you have already seen that there was no sperm at all. Okay. So once you understand these fundamentals, if you move into seminology, it becomes easy to now understand the whole concepts and appreciate it extensively. All right. Good. Please don't hesitate to ask questions as we move along. All right. So yes, dear.
Please, so when you are doing the post
ejaculatory urine
the PU,
yes,
the analysis, are we supposed to do the whole urinalysis or just report maybe the presence of sperms
so
or
what
not?
is your focus? Your focus is that you want to establish the presence of semen. All right, so of semen, and with this semen, your target is the presence of sperms. Okay, so that is your focus. However, if along the line you also see a lot of passes on blah blah blah, you can report them. But you see here, your diagnosis, you are not going to diagnose UTI. That is not why you are doing the analysis. If you want UTI, you just collect early morning urine or any midstream urine. You understand? You don't need post-ejaculatory urine sample to diagnose UTI. Do you get a point?
Yes.
So it's like what are you looking out for? You are looking out for sperm in the post-ejaculatory urine. Okay. However, along the line, if you also saw a lot of parcels, you could also report on that. What if the parcels is not coming from the urine per se? Okay, it's not coming from the urine per se. It's coming from, and we'll deal with that one, pyospermias, where there are a lot of parcels in the listing, because if the patient has let's say testicular infection or epididymal infection or anything, then any infection along that tract, they come along with parcels. So the fact that you saw parcels in urine, the post-ejaculatory does not confirm that you have UTI. You get that point? So that's why we are condemning the element of fructose testing in the PUU. Because the fact that fructose is high, you cannot pinpoint that then it's coming from this. What if the patient also has a problem with fructose analysis or fructose metabolism? You understand? So once you're able to raise a point against the credibility of a certain report, that's all. It means that that report is not reliable. Are you following, my dear?
Yes, please.
So what I'm saying that you can report on other things, but that is not your focus. Your focus is on the sperms. All right, good. Now, let's see how you prepare our patients. These things are very, very, very important because the way we prepare our patients will give us the right or the quality specimen that we want. And remember, like we've always been saying, garbage in, garbage out. if you have a compromise or poor quality sample, your results is also going to be bad, no matter how experienced you are. So the other day, I think we just mentioned that, for example, if a doctor requests for testosterone level in the lab for you, and then the patient comes to you in the afternoon, and then also, okay, oh, we pull our samples, we take all the hormones, and then we run them. So the patient like, oh, let me collect it, and then you collect the semen, sorry, the sample around, let's say 11 o'clock, 12 o'clock, thereabout, without knowing that testosterone is highest in the mornings, and therefore collecting the sample that day, you are likely going to have a low testosterone level. Then what are you, a scientist or you are a robot? You see, so I want us to be able to understand the things that we're doing, how to prepare our patients to be able to derive the highest quality sample to be able to give us the right results. All right, so let's go through the post-ejaculatory analysis, how we should prepare our patients and how the sample should be collected. And once you're able to do this very well, you are sure that if you say that the result is A or B, it is nothing but the truth. So what are the specific instructions to give to our patients? So before preparing a patient for the PU test, these are the things that the patient should do. It should have gone through an abstinence. Abstinence means when it's a sexual abstinence, that is avoiding sexual activity for between 2 to 7 days. Okay. So we are also saying that the sexual abstinence can also include ejaculation. Remember that somebody may have what do you call it? Nocturnal ejaculation issues, where you can before in the night you have some sweet dreams, and then before you could say Jack, you have ejaculated. Once that has happened, it should be considered that your abstinent period have been compromised, and therefore you have to start again. All right. So, and we will emphasize on these things when we are doing the semen analysis. All right. So you don't have to have sex or masturbate, or not to have experienced nocturnal ejaculation during the period that you're talking about, and that's 2 to 7 days. So it should not necessarily be 7 days, and then it should not necessarily be less than 2 days. So if you have met that condition for 2 days or 3 days to 4 days, that's also allowed. Now, the day before the test, the patient should drink a lot of water before the previous night. All right. Why? Because remember, we're saying that we want to be sure that the urine is not by itself cloudy. Okay. The urine by itself is not cloudy, because if the urine itself is cloudy, it gives you a false impression that, oh, the post-ejaculatory urine sample is cloudy, and therefore already you are suspecting that then it is positive for retrograde ejaculation. But once you take a lot of water, you have urinated a lot. Once you urinate a lot, it means that the urine which is coming out at the latter part or in the morning should be clear. I hope that point is clear. Because even if you don't urinate too often, you'll have all the water that you've taken in will have diluted your urine. Once it dilutes your urine, it makes, remember that a diluted urine cannot be cloudy. Okay, so it removes that concept of cloudiness. So that is that. All right. So in the morning too, you have to empty the bladder. So we have allowed you to drink in a lot of water the previous night, so that you can clear the system in a manner that in the morning the urine that you void is very clear and will not be already cloudy to cause any diagnostic challenge for us. So after you have emptied your bladder, you wait for about half an hour. You wash your hands and penis, and then you masturbate. All right. Now,
hi, please, I have a question.
Yeah, please do.
At the area of the abstinence, what if a patient come who have abstained from sex like a month or more than 7 days? How do you go about one to?
All right. If it's for already a suspected case of post-ejaculatory urinalysis, so if a suspected case of retrograde ejaculation, that timing probably it will be okay. But if it is for semen analysis, you will not allow that, because in semen analysis, motility of the sperms is very, very key. Okay, as we move along, you realize that prolonged masturbation will also reduce motility of the sperms. All right, so if the patient comes and tells you that, oh, I haven't had sex for about 1 month, and so you take the sample, you see that with a prolonged ejaculation or prolonged, what do you call it, abstinence, one, you increase your chances of the sperm count. All right, that one, no two ways about it. Sperm count will increase, but it is also going to compromise on the sperm motility. So a lot of the sperms will have died, and so you see that you come to square one. So in preparing the patient, we don't want any doubt. For example, we said that we don't want any doubt about the cloudiness or the clarity of the urine. So we have given you water the night before to be able to clear the system, so that we are sure in our minds that if the urine is cloudy, then it presupposes that it has been mixed up with the seminal fluid. Okay, so we don't want a situation where, oh, the patient has low sperm motility, and then the question becomes, oh, then it is because he has what do you call it? He has abstained for a long time. We don't want anything, any bad to be. So we come to that situation when we do seminology. I'm saying that here our emphasis is on looking for sperms in the urine. Our emphasis is not going to be on motility. Okay, as we move along, you even see that even sperms, even exposure of sperms in a urine environment will kill them anyway. Do you understand them? You understand that? Because the urine will have been acidic. And we've said that from the beginning that sperms are killed instantly or within a very short time by exposure to acid. So here, our emphasis is not on the motility. Our emphasis is on the presence of the sperms. And so the long abstinence, well, may not matter. But at the end of the day, we want to be sure that the result that we are going to get conforms to international standards, that if you do your test by all protocols anywhere in the world, that is the approach everybody does. I hope that point is clear. So that's why we're saying that let's go by the SOPs, the standard operating procedures, and this is where it will be the same thing across board, so that you don't give room for 1 month or 3 weeks of abstinence. Okay. Right. So now after masturbation, then because once you masturbate, you expect that ejaculate will come. Okay. So once the seminal fluid is coming, you collect it into your sample container. If nothing comes, and that will have been dry orgasm, okay, or aspermia, that's okay. So it is okay if there is no ejaculate. Because at the end of the day, already you are suspecting that the semen, instead of coming, is rather moving backwards. So if nothing comes after a masturbation, at least the emission phase will have taken place already. All right, the emission phase will have taken place, will have brought the sperms from their resting place to the prostate area. And instead of the second phase to move them out, they rather move backwards. That's already your suspicion. And so If nothing comes, then it means that the presupposes that the semen has moved into the bladder. And that is what you are actually investigating for. Okay. So soon, the next point is soon after the ejaculation, urinate into another sample container. So it means that you will have had two containers, one for the semen and then one for the urine. So after the masturbation, if some of the semen is coming, you collect into your container. If nothing comes, that's okay, but you don't, that is not your emphasis. Your emphasis is that you're already suspecting that the ejaculate, or for that matter, the semen fluid has moved into the bladder. So your interest is in the urine, which you are going to collect afterwards. All right. So you collect that urine container. Sorry, you collect that urine, put it into the container, and it should be all. Let the person urinate everything. Even if from beginning to the end, everything should come out. All right. And then you submit. Hello.
Okay, Grandpa.
Okay. All right. Hello.
So, hello, Grandpa.
Yes, please.
So with this protocol now, I'm now understanding why when some doctors request for semen analysis and then at the same time urine for culture and sensitivity, what it means is that the semen should be produced first, even before the urine is taken. Is that it?
Right. If it depends on what the doctor is suspecting.
Sure. Sometimes we have request forms for semen analysis and at the same time urine culture. So my question now is, which one should be produced first when it's in this situation?
They are all for two different. The urine culture is to rule out urinary tract infection. Okay.
Sure.
Infection. And that is a completely different from the semen analysis.
Sure.
All right. So you can do the urine culture can be done anytime without abstinence, without anything.
Sure.
Okay. So you can do the urine the time that the patient comes in, no problem. You want to rule out the fact that he has UTI or no UTI.
Oh,
okay. It doesn't have to be done the same day. No, not at all.
Oh, okay. Okay.
Right.
Thank you.
Okay, you're welcome. But if he wants you to examine urine after this, then he's suspecting that the urine, the semen, not all comes out.
Oh, okay.
But some also goes into your bladder. And that one, you don't even need culture. You only need post-ejaculatory urine examination. That's all.
Sure. Sure.
Okay.
Thank you.
You're welcome, sir. Still on the
All right.
Yes, sir.
This is Alex. I want to ask, even after the client has urinated early in the morning in the house,
okay,
can the client still urinate before the process begins? I mean, production of the semen begins, then we take the post ejaculatory urine.
You see, the post ejaculatory urine, one, it has to be requested for. Okay, it has to be requested for, because anything that you do in the lab, it ought to have been requested. Even if you want, if you are suspecting something, you can only recommend to the doctor for the doctor also to make the request. Okay, so I don't want it to be a situation where the post-ejaculatory urine analysis becomes like part of your routine things that you do in the lab. If the urine, you are doing semen analysis and the semen volume was so low, and you, from your own investigations or from your own preparation of the patient did not do retrograde coitus interruptus. You will come to that later on. Like I've said, in the coitus interruptus, if the semen volume is low, you cannot immediately suspect retrograde ejaculation. I want you to suspect probably loss of specimen in the course of the sampling. I hope that one is clear.
Yes, please.
So all these things will become very clear when we do this, the seminology. That these things are part of the andrology, and it gives giving you some fundamentals or some basic information. So if you are going to do the urine analysis after your semen analysis. There should be a basis. Are you suspecting retrograde ejaculation? That's the first thing. If you're not suspecting it, then the issue of urine collection is not necessary. I hope that point is clear.
Yes, please.
Unless I didn't get your point.
Yeah, it's clear. It's clear.
So don't be going about doing it just for the sake of doing it. If you are suspecting it, you can make in your comment. If you do a semen analysis, you can make in your comment that you suspect or query retrograde ejaculation. All right, and then you request that you suggest post-ejaculatory urine sample for analysis, so that the doctor will now know that, hey, the lab people, they know something, and then the request will come. Probably even this one is not part of the urinalysis. That one you can charge differently, because this one is not for, you cannot charge the patient as urinalysis, because something must go inside. And so it can be a special test, so to speak, and then you charge. All right. So,
but Graham, I want to know your advice on this situation whereby a client has produced a semen and dry orgasm, as you are saying.
If there's dry orgasm, then he cannot produce the semen. No. Come again. If the patient has dry orgasm, it means that he cannot even produce the semen. So in that case, all that you do is that patient dry orgasm. So then you will suspect retrograde ejaculation. So you ask the patient, you send a report to the doctor for the doctor to make that request.
Oh, okay.
So the doctor know that you know something.
Okay.
Okay. In the lab or elsewhere, they have what they call reflex testing. Reflex testing is not reflex action. Reflex testing is where, let's say, a doctor does request for sickling. Okay. And then you do your sickling and it's positive. I'm not sure you, the lab, will go ahead and then do electrophoresis. Is that what you do? You do your test. And the sickling, not required for sickling. And then you did the sickling positive. Will you go ahead and do the electrophoresis?
Oh, you will do that.
So that you take the report to the doctor for the doctor to come and now make a request for electrophoresis. Elsewhere, they have what we call reflex testing, where the doctor will say that if you do sickling, then you can write reflex electro. What it means here is that if you do your sickling and it's positive, don't bring the report back to me. Go ahead and do the electrophoresis. Similarly, you can have urinary reflex CS. What it means is that you do your urinary. If from your RV there's a high suspicion of an infection, you don't take the report to the doctor, but you make the patient produce a specimen and do your urine CS. But here, I'm not sure the clinicians are used to this reflex testing on the lab too. I don't know, but what I'm saying that when you say reflex testing, what it means is that you can go ahead and do the next level test if your initial test proves something else. That doesn't make sense.
Yeah. Yes, please.
Yeah. So because every test there must be a request. Every test there must be a request. The requesting clinician must know that must know what he has requested. Okay, and then you are in the lab. There should be a basis for doing a certain test. So if the doctor makes the reflex testing, then in that case that, okay, you do A. But if the A is giving you indication for B, go ahead and do the B. Okay. Otherwise, you only send the report to the doctor, the A report to the doctor, for the doctor to come and now make the request for the B. And then that is the normal thing. Is that all right? Is that all right? Have I answered your problem?
Yes, please. Yeah,
okay.
Yeah, that's right.
Okay. So still on the post-ejaculatory urine examinations. Remember, you said we can have post-orgasmic urine sample, where the patient tells you that, oh, I've gone through sexual activity, or I've done masturbation, and I feel that I have an orgasm, yet nothing comes out. Then you can have a post-orgasmic urine sample. You can have post-ejaculatory urine sample where there has been an ejaculation, and then you are not satisfied that it is enough, the volume which is coming out is not adequate enough. You suspect that something has gone back. Or post-masturbatory. I've explained all these things. They all come to the same point. They are all one and the same. But you should understand that certain terminology should be used based on certain actions that preceded it. Okay. So any of these samples will be analyzed for physical, chemical, and microscopic examination. You said this already. Now the post-ejaculatory urine sample will be centrifuged, and the cells present in the pellet, you know, the pellet is either the sediment or the deposit, will be assessed for type and quantity. Okay, just as you do for any microscopy, urine microscopy. So post-ejaculatory urine microscopic examination for sperm. So these are the things that is of interest to you in the lab. Okay. So the urine sediment is examined under a microscope to identify and count any sperm present. Microscopic examination for detection and assessment for significant number of sperm in a post-ejaculation urine can easily diagnose retrograde ejaculation. I think these are just more slides on the things that we've discussed already. So the post-orgasm urine or post-ejaculatory urine sample is adequately mixed and poured into tubes. Remember, we said that in the post-ejaculatory urine sample, it's not like urinary, where you ask the patient to give you just some small amount of volume, say about 10 ml of urine or blah, blah. No. Here, you're asking the patient to give out everything. He has to empty the bladder. Okay, he has to empty the bladder. All right, because you are interested in assessing even the number, not just the presence of sperms, but even the number of sperms. All right, so if he is producing the urine and then he leaves some of the urine sample, he leaves some, then it means that you are unable to assess the full strength of the sperm samples, or sorry, of the sperm cells. So you need everything. Since you need everything, if let's say even the patient is bringing in about 50 mL, it means all the 50 mL will have to be centrifuged. All of them, you have to pour them in different tubes and spin all of them. After spinning all of them, of course, you decant your supernatant, and then now you can pool your deposits or the pellets. If let's say you had to use about 4 centrifuge tubes to spin all of them, then at the end of the day, the deposit or the pellets or sediments that are obtained from the 4 tubes, you have to pool them together. And now you are going to mix them together and then examine them. All right. So the procedure again. So each of the tubes, just as you do for any urine deposit, they have to be centrifuged for 10 minutes at 1,500 RPM, after which the supernatant is removed, leaving behind the pellet. The centrifuge pellet of all tubes are pooled and examined microscopically for the presence of sperm. The number and motility of sperm in the urine are assessed. But here, take note, the motility is not too much critical here, because we said that once the sperm go into the bladder, they have contact with the urine. Urine is acidic, and sperm cells cannot survive the acidic environment. All right, so as for motility, just put it down, but that is not the critical indicator to diagnose retrograde ejaculation. I hope that point is clear. Right. Good. So whether the sperms are alive or dead, once the sperms are there, they could mean something to confirm your diagnosis. If sperm cells are seen in the urine sediment, then assessment of the numerous present shall be necessary to confirm or rule out the diagnosis of the RE. So what are the indications for positive PUE? Finding a significant number of sperm in the post-ejaculatory urine sediment suggests retrograde ejaculation. And then here we're saying that if you have sperm cells of greater than 5 per high power field in a post-ejaculatory urine sediment, it confirms a diagnosis of RE. Negative PUE, that is a lack of sperm in the urine may indicate other issues with ejaculation or sperm production. So if you don't have sperm in the urine, that's the post-ejaculatory urine, it could also indicate that there are issues. For example, we said that if the patients already have low sperm count, very low sperm count, then the semen will have moved into the urine, all right, but probably the count that you get will not meet the threshold for diagnosis, because you say you want more than 5, at least more than 5 sperm cells, and you are seeing 1 or 2. So 1 or 2 does not meet the threshold for diagnosis. So you say that the retrograde ejaculation is not possible. Okay. Meanwhile, the patient himself has a low sperm count. So that are some of the limitations of the PUE analysis. All right. So this is just also an example where sperm cells were less than 5 per high power field. And in this report, retrograde ejaculation, we say is unlikely. Okay. But remember, this also becomes the limitations of the PUE for diagnosis. So PUE results should be interpreted alongside the patient's overall clinical picture and the other test results. What it means is that before you can interpret very well, other things should be taken into consideration. For example, what's the patient's sperm count? If the sperm count is already very low, then if you don't take care, you will say that he has a negative PUE. Then you say that no, retrograde ejaculation is not possible. Meanwhile, the patient's own natural status is that he has low sperm count. Okay, right. While a high number of sperm in the urine is suggestive. So once the sperm count is very high, that one it makes your diagnosis very simple. But a small sperm count can become a challenge. So that is all about the retrograde ejaculation. I'm sure that you have understood the pathophysiology of the retrograde ejaculation and everything, the lab, your role as a lab scientist, how you can, first of all, how you can pick up the suspicion, okay? And then how you can also go ahead and then do the laboratory test to confirm. And then also the fact that the fructose analysis, elsewhere people are using it, but we are saying here that it is not a reliable approach because of other factors. All right. So all that we're relying on is the microscopy. Okay. Any question, please? Okay. Okay. So now let's look at other ejaculatory disorders. So you also see that the retrograde ejaculation is an ejaculatory disorder because ejaculation is the normal ejaculation is the antegrade process where the flow should be forward. Okay. So since in the retrograde ejaculation, the flow is backward, it is also part of ejaculatory disorders. All right, so here we say other ejaculatory disorders. So the main ejaculatory disorder is the retrograde ejaculation, but there are other disorders associated with ejaculation. So you have hematuria, also called orgasm-associated urinary incontinence. Remember, urinary incontinence is like inability to control your flow of urine. All right. You can't control your flow of urine. And in this scenario, the person is having an orgasm, and therefore orgasm is going to come along with ejaculation. At the same time, the patient is producing urine. And the urine here, the patient is unlikely to control itself. All right. And that is here, instead of having a retrograde ejaculation, rather the urine is now mixing up with the what do you call it? With the urine. So with the semen. All right. And that is, I remember I sometimes you hear some story, they say that, oh, there's a gentleman, a guy who hadn't had sex before. And then once he was having sex with a lady and there was orgasm. Also, emergency, then also Jinsogum. Jinsogum. You see, if it's Jinsogum and you allow him to Jinsogum, it means that it's going to produce, it's going to have orgasm and urine at the same time. And that's climacturia. And remember, that is going to be serious because remember we said over and over again, any mix of urine and sperm will cause the sperm to die off because sperm cannot survive in an acid environment. So if this condition continues, the patient is like, so when you're going to have infertility, male infertility, then all these things will come out. If somebody has orgasm-associated urinary incontinence, that patient is going to have challenges with ability to fertilize or to produce viable sperms because the sperms will die because they're going to have contact with the urine. Okay, so that's climacturia. Climacturia is a common side effect after radical prostatectomy. And prostatectomy, when it's radical, it means that the whole gland has been removed, including surrounding tissues and so forth and so on. All right, so once that happens, at the end of the day, it's going to affect the capacity of the individual to control itself during orgasm. Okay, during orgasm, then urine will also be passing along, and that is climacturia. All right. So hemospermia, of course, this is simple to understand. Hematospermia, hemospermia, they are the same thing. And that's the presence of blood in the semen. All right. It can be visible as bright red or dark brown. If it is bright red, it means that it's a current blood flow. If it's dark brown, it means that the blood has is an old hemorrhage or old bleeding. Okay, that's all. All right. It is usually a painless, benign, and self-repeating symptom. Okay, so we also have persistent or recurrent hematospermia. Sometimes this thing can occur occasionally, and then it may not occur again. All right. As scientists, you should know all these things so that once you have this thing, you will be in a better position to also advise your patients or clients. Sometimes certain people come in already frustrated, distressed about certain conditions that they are seeing. And then once you have the necessary scientific knowledge and information, you'll be able to calm down their nerves. And then they will also now, it will also be part of their healing process. Okay, right. Persistent or recurrent hematospermia can be a potential early sign of prostate cancer. This one, it is something you have to know. If you say that hematospermia, if it's an occasional one, it may not even come again, and it's benign, it will stop. But if persistent, the entire the patient produces the semen, there's blood in it, then it could be an early sign of prostate cancer, especially for those who are men over 40 years. And therefore, in that case, the diagnostics approaches for prostate cancer can now be rolled out. Okay. So causes of hematospermia. Potential causes of hematospermia include transrectal ultrasound. And truths, you should know some, because sometimes some of these things come to you in the lab. and you should have an idea what it is. All right. Transrectal ultrasound, that will be TRUS, guided prostate biopsy. The doctors will use a form of an ultrasound. All right. Of course, transrectal means through they will use the probe, they will pass the probe through the rectum. That's the transrectal, and through that they want to probably take a biopsy from the prostate. Once that happens, the prostate will bleed, and once the patient is going to have produce semen, of course, there will be blood in the semen. That is hematospermia. But of course, you know that this could be temporary. All right. If there's a major trauma, injury to the male sex organs, it can cause hematospermia. Any infections that affect the prostate, seminal vesicles, epididymis, it can also cause hematospermia. And the ejaculatory duct obstruction, you know the ejaculatory duct, all right, where you have the vas deferens, the ampulla, and then the seminal vesicles duct, where they meet, that's the ejaculatory duct. There can be an obstruction there. And once there's an obstruction there, it can cause a bleeding. So that's the ejaculatory duct obstruction. All right. So we'll finish soon. I want us to get the next line, and then so we're going to look at other penile conditions and disorders. All right. So some of the penile conditions here, we're going to talk about some infections that affect the penis. So we have one called balanitis, okay, posthitis, and balanopostitis, and psoriasis. Okay, so we will deal with the balanitis for today. God willing, tomorrow we continue from there. All right. So balanitis, you know our penis. You have the head, the shaft. The head is also the glans. We have the shaft, and then the root. Okay, and then of course with the head, if it is uncircumcised, you have the foreskin or the prepuce. You know this already. Then there can, especially the glans side, the head side, with the foreskin, that is in uncircumcised patients or individuals, they can easily get an infection. I remember the suffix itis. The suffix itis, what does it mean? Medical terminology. Well, if you have a suffix
Inflammation.
ITI, inflammation or infection. Okay, right. So vaginitis, cervicitis, and so forth and so on, conjunctivitis, a whole lot. So balanitis is infection affecting the foreskin. All right. So you see that if that's the case, then it means that if you are circumcised, you're unlikely to have balanitis, because you are having, this is infection that affects, this is inflammation of the head, Sorry, we're going to talk about the other side. Sorry. So this is infection affecting the head of the penis. Okay, not the foreskin. Sorry. It can be classified as infectious balanitis or non-infectious balanitis, depending on the causative agent. So once there's an infection or infectious agent, it can either be a bacteria, a fungal cause, bacterial cause, or viral cause. Okay, right. I think I'm also getting tired. So let's stop here. Tomorrow we start with the infections, and I don't have to. We have a lot of time. So you end here for today, and we start with the balanitis from tomorrow, and then we do all the rest tomorrow. Please, if you have any questions, let me get them.
Hello, Grandpa.
Yes, dear.
Please, I want to ask a question. You see,
Please
some
do.
people, when they come to do semen analysis, some of them, the liquefaction is not like how it's supposed to liquefy. It's not like that. Please, that one too. What can we say about it?
All right. Remember, we are moving step by step. And
Okay.
we said overall again that we are dealing with andrology, and here you're dealing with the male reproductive system and all the organs, what they do, what infections affect them. And so the only thing we are not doing on the andrology here is the treatment, because we said that we are dealing with laboratory andrology. And when it comes, as soon as we enter into treatment, that becomes clinical andrology, and the doctors will think that we are taking their job, and that can create a problem. So we are dealing with that. Then you see that when we are done with the andrology, we do semenology. The semenology will cover all aspects, including semen analysis. The only thing we are doing here again too is that the understanding or the knowledge we are getting from andrology will help us to understand the concept of the semenology very, very, very well. Okay, right. We would, even if we haven't done the semen analysis or semenology, you should be able to answer this question yourself. Why semen will not liquefy? If semen will not liquefy, so many things, so many factors, right from the sampling. Remember, even we haven't done the semen semenology, but we mentioned that during ejaculation comes in fractions. The first part is predominantly fluid from the prostatic fluid, and then also the sperm itself. Because now, after emission, everything has come to be centralized within the prostate. All right. And then the first portion that comes out, apart from the pre-ejaculate, which is from the bulbourethral glands, all right, which lubricates the urethra. Apart from that, the major fraction, the first fraction, is coming from the prostate. And the prostate, the prostatic fluid contains the proteolytic enzymes. And we are saying that the proteolytic enzymes, they are the ones that will now, once the specimen has coagulated, they will now decoagulate. They will now make sure that the semen becomes liquefied. So if the patient produces the semen by coitus interruptus, which most of the time people do, a lot of the time they miss out the first fraction. I think I've said this several times. A lot of the time by coitus interruptus, they lose the first fraction, because before they will remove or withdraw, I mean, unconsciously, the first part is already gone. So a lot of the time, the semen that comes out is minus the first fraction. The first fraction, apart from the fact that you are losing a lot of sperms, we are also losing the prostatic portion, the prostate portion. The prostate portion too is the one that contains the proteolytic enzymes. Okay, those ones that are supposed to break down the coagulum. So if that happens, of course, you expect that the sample will be standing there for hours. It will not coagulate. Okay, so if semen is not liquefying, your target, your source of the cause is likely coming from the prostate. Either the prostate function is not functioning well, or the prostatic fraction of the sample was lost. Okay, we will deal with those ones again, but I'm saying that if semen is not clotting, it is coming from the seminal vesicles. Okay, if semen is also not liquefying, it is coming from the prostate. Okay, these are the important things you have to know. And if it is coming from the prostate, what are some of the possible causes? Possible causes is that the prostatic proportion of the seminal fluid may have been lost. How is it lost? It's lost through the sampling. Okay, the sampling we've said that, and I've just said it again, that it is the first fraction contains largely the proportion from the prostate, and also a large amount, about 70% of the sperm cells. You will deal with them again when we come to the seminology proper, but I think this should suffice for now. Are you okay?
Yes, sir, Grandpa.
Any other question, please?
No.
Any question?
No, please.
Are you satisfied? Are you okay?
Yes, sir.
Okay. I think I said that we are going to have interesting. I don't know how interesting it was, but I don't know whether you are disappointed when I said that
No.
interesting topics.
It's fine.
It's fine. Okay.
It's fine. It's related. It's like chain. So
okay. All right. Yeah. So you understand one aspect and then it flows into the other, blah blah blah. So that's why I'm saying that if you're able to deal with the andrology, it will make the semen, the seminology. Remember, seminology too will also capture the semen analysis. Before we come to the semen analysis, you do the what we call the spermatogenesis, how sperms are actually produced from A to Z. Okay, and a lot of the information will have been covered already from the andrology lessons. Okay, and I'm sure that at the end of the day, you like I've said over again, you'll be able to have a feel that you have some quality knowledge in the area of semen analysis and andrology. All right. Okay. On that note, we call it a day and see you tomorrow, God willing. Bye-bye.